So, good evening, everyone. I'd like to welcome everyone to tonight's SMRC webinar, Patellar Tendinopathy, Pathology of Joint Using Sports Ultrasound. I'm Jackie Sandoval. I'm one of the AMSSM SRMC officers this year, serving as the family medicine rep, and I'm pleased to serve as the moderator for tonight's webinar. I'm currently a third year at Kaiser Los Angeles in California. My interests in sports medicine include ultrasound, which I've been teaching and participating in since medical school. I've now started the ultrasound curriculum in our program. I'm also interested in combat sports and baseball. I like kickboxing and Muay Thai, which encourage my interests, and hope to do a hybrid FM sports med in the future, and then hopefully some sideline coverage in both sports. Tonight, it is an honor to have Dr. Troy Henning serving as our featured speaker. After this presentation, I'll serve as the moderator for the Q&A. So for tonight, I'll read the questions entered into the chat, and then I'll ask Dr. Henning to respond to those questions that you all put in there. And then just please enter any of the questions in there at any time during the webinar, and then I'll read each one during our Q&A segment. And then Dr. Henning will respond to them. So now it is my pleasure to introduce Dr. Troy Henning. A small background regarding him. Dr. Henning practices sports medicine for Providence Swedish Medical Center in Seattle, Washington. He's the medical director for the Sports and Performance Medicine program and director for musculoskeletal ultrasound for the group. Dr. Henning is also the chief medical officer for the Seattle Sounders Football Club. He trained in PM&R at the University of Washington and then completed his sports med fellowship at Mayo Clinic in Rochester, Minnesota. He has numerous peer-reviewed publications on the evaluation and management of various musculoskeletal injuries, the application of diagnostic ultrasound, and guided procedures. He has been an invited speaker to a variety of professional organizations, including the AMSSM, APM&R, and the AIUM. Dr. Henning has also served as the director of the AMSSM Advanced Sports Ultrasound Pre-Conference for the past 3 years. So Dr. Henning, you can begin your presentation.
Great, thank you so much for that introduction and invitation to give this presentation here. So yes, I'm going to discuss the patellar tendinopathy evaluation and management strategies. I have nothing to disclose. The objectives of the lecture will be to briefly describe patellar tendinopathy, some of the sonographic imaging characteristics of it, and then review some of the evaluation and management strategies, as well as some detailed examples of ultrasound-guided interventions. I think most of us understand this, but I still see or hear these terms being confused a little bit. So I think most of us learn about tendons, call it tendinitis. It's sort of stuck in the vernacular of like lay press and patients and some providers. But really, in modern days, we think of this as not being an inflammatory problem, but more of a degenerative problem. So using the term tendinopathy, in this case, patellar tendinopathy would be the preferred clinical term. Sometimes I'll still use tendinitis if patients kind of look at me when I say tendinopathy and they just get stuck on that term. But I really try to emphasize the lack of inflammatory kind of process. And I think that also helps them understand the treatment options that I'll outline to them as well. So patellar tendinopathy, it can be a very common thing. It's seen more commonly in jumping type sports, hence the term jumper's knee. So for instance, in professional volleyball and basketball, it accounts for 45 to 32% respectively. And then it becomes a little less common as we get down to the lower levels and down into the amateurs. It's more around that kind of 8.5%. There are some risk factors that may predispose people to developing this process, such as the number of hours they're involved. So it kind of makes sense that professional athletes would be involved in a lot more hours than someone like myself. And it's also interesting that in this case, males tend to be afflicted more than females, whereas I would say for most other musculoskeletal problems, women tend to suffer more than men. Some of the issues may relate to how the person lands when they're coming down from a jump. So they may land with a little bit stiffer leg, which may impart more force at the patellar tendon. And then the surface that they play on, those being harder surfaces, which again makes sense with volleyball and basketball, at least indoor volleyball. Sand volleyball players tend to be have this problem less often as a result. Some of the positions also play a role. So as you would imagine with volleyball, for example, the outside or middle hitters would be more exposed to the jumping and landing in a repetitive fashion, more so than somebody like the setter. This isn't old, but I think still relevant. Kind of injury diagram here. It kind of describes the pathology that's involved. And when I talk to patients or other providers about tendinopathy, I envision this in my head. I've given this talk a bunch of times and it's sort of stuck in there, but I think it's a good model that helps explain how these processes start and when patients sort of present to clinic. So there's something, as we just discussed, some kind of repetitive load that the person's seeing, or maybe they had an injury and there's some underlying kind of injury already there that's being overwhelmed by the load they're asking it to accept. Or perhaps there's some kind of chemical injury, like they took a medication, or they ingested some kind of substance in the environment that injured the tendon tissue in a way that they're just unaware of. Sometimes there is viruses or bacterial infections that have also been thought of as causing or initiating an injury response in a tendon. Some of these people will go on to the second stage or this failed healing stage. For whatever reason, their bodies aren't able to clear the tendon injury, or they kind of continue down this paradigm here. So in this failed healing stage, it's thought they may have some kind of genetic predisposition. So the person that has tendinopathy in one area, they may end up developing in a bunch of different areas. So you'll see people come in with gluteal tendinopathy on one side, and then they'll have rotator cuff tendinopathy a couple of months later. So there's something within that person that's kind of predisposing them that more than somebody else. As I kind of alluded to, women generally suffer more from musculoskeletal injuries than men, but except in the patellar tendon area. But for most of the patients that get tendinopathies, it's usually an older population, so somewhere around that 40, 60-year-old range, kind of that peri to postmenopausal female that obviously has some hormonal changes going on. So that may be leading to this failed healing response. And then maybe there's some external factors that are involved, such as maybe they're a manual labor, or as I mentioned before, a professional athlete. And they can't really like take time off or reduce the load, so they're constantly exposing themselves to that injurious force there. Or maybe there's some kind of pharmacological problem or exposure that they just can't stop because they have some of the medical problem that supersedes treatment for their tendon problem. The tendon will then continue to go on to fail, and I'll go through this degenerative cascade. So the normal tendons are predominantly made of type 1 or type 2 collagen, and when they start to break down, they turn into more type 3, which doesn't have the same tensile loading properties, so it kind of becomes weakened and fails more easily. The tissue also becomes hypercellular, so that draws in, if you remember Starling forces, it'll draw in water, interstitial fluid into the area. It makes the tendon look thickened. The patients will complain of it looking swollen. On imaging, especially like MR or ultrasound, you'll see fluid changes in the tendon tissue, and that's where some people kind of conflate it for being inflamed, when in fact it's really just an increased amount of interstitial fluid. As the disease process continues, there are cytokines that are being released. Some of them introduce or provoke neovascularization into the tendon. So you'll see a ingrowth of blood vessels coming into the tendon from some adjacent tissue. Generally, there's like a fat pad or a bursal layer next to the tendon where the vasculature goes into the tendon, along with blood vessels. Then come free nerve endings, and that's where you get the release of substances such as like calcitonin gene or that related peptide, substance P, et cetera. So that's when the person may present with pain. Not to make it too overly simple, but really it should be a kind of a simple diagnosis to make. If they hurt at the inferior pole of their patella at the patellar tendon, they should have patellar tendinopathy. Versus if they're not really tender there, the same population also has or can have other diagnoses such as patellofemoral pain syndrome or patellofemoral arthritis. I'll often see patients where it's hard sometimes to differentiate patellofemoral joint from patellar tendon issues, or maybe they have this dual kind of problem going on at the same time, and they have to have some clear understanding what is their primary and or secondary generator of their pain, because if they're not responding to the treatment of their tendon, maybe it's the patellofemoral pain that's causing a persistence of the problem. If you're not really thinking it's an intra-articular process, then look higher. So think about the hip or neurologic, such as like a radiculopathy causing refer pain down to the front of the knee, because sometimes a more proximal source will mimic something more local. And when we think of evaluation, we should also think of imaging. So I often, almost as a rule, get radiographs on just about anybody that's coming in with any kind of joint area kind of pain, right? So I like radiographs are a nice complement to other imaging such as MRI or ultrasound. As far as looking at radiographs, you're looking for things that might be associated with tendinopathy. So there's some good evidence like in the shoulder or at the trochanter in the hip. If you see cortical irregularity there along the emphasis or the area where the tendon attaches to, there's a high likelihood that you'll find abnormalities on an MRI or ultrasound. So in this case, looking at the inferior pole, you're kind of looking for a pitted or kind of moth-eaten kind of appearance of the bone that might suggest a patellar tendinopathy. You can also look for those other competing diagnoses such as patellofemoral arthritis. MRIs and ultrasound are then kind of next steps if you're thinking it's a soft tissue thing. I think in the US, the MRI still kind of beats out ultrasound as far as use, but the ultrasound is becoming more common. MRI, you're looking for, again, those changes in fluid shifting. So like I said before, there's an increased amount of interstitial fluid. So you're looking at those fluid sensitive sequences to look for the abnormality in that proximal kind of deep or posterior portion of the tendon. On ultrasound, it's kind of the opposite. We see a thickened tendon. We'll see it be hypoechoic as opposed to hyperechoic. It will have lost its nice fibular or kind of linear arranged fiber orientation. You can still see the cortical irregularities, and then you can also, in this case, look for those neovessels or that neovascularization with turning on the Doppler imaging. In this case, power Doppler imaging would be preferable over color. It's more sensitive to these low blood flow states and would pick up more of the pathology if you use that one. So this image here on the left demonstrates a sonogram of a normal patellar tendon. On the right is proximal, left is distal, top will be superficial. So looking from the skin down through the fat layer here, you see the tendon. Normal tendon has this nice fibular compact structure. It's all uniform in its appearance all the way up to its insertion, or in this case, origin off the patella. Deep to it is Hoffa's fat pad here. And then on the right image, it's the same orientation. Right is proximal, left is distal. In this case, the tendon is not normal. It becomes thickened as we come up to the patella here. It's kind of heterogeneous. It lost its nice fibular pattern. Here, I don't really see any fibers at all. This kind of I liken to like a sponge as opposed to stripes of tissue. And then this orange reddish kind of stuff is that power Doppler. So you can see the neovessels growing up from Hoffa's fat pad up into the tendon. And these are all the kind of classical kind of things that we would see in somebody with tendinopathy, whether it's the patella or the Achilles or wherever. Here's an MR, a different patient, but the idea is the same. So this right image here is a sagittal. As you can see, here's the patella, femur, and tibia, respectively. This is their patellar tendon coming off the tibia, migrating up to the patella. And here again, on this fluid-sensitive sequence, you can see all the fluid here in this proximal, relatively posterior portion of the tendon. Looking at the axial then on the left here, again, the top is the anterior aspect. So this is the patellar tendon. You can see right in the middle 1/3, as it's classically seen, is a large kind of pocket of fluid in this case, a high-grade tear of the tendon in this particular patient. So it looks more obvious here on MRI, ultrasound. You know, if you do it frequently enough, it'll look obvious. Sometimes it can be subtle looking if you're less familiar. Classically, the patellar tendon, when we talk about it, we think of it as being at the top proximal or where it rises off the patella and the deep surface of that tendon. On a rare or less common occasion, you might see it distally, right? So here's the patellar tendon. In this case, it's coming down into the tibial tubercle region, and you can see it becomes thickened as it comes down. It's somewhat heterogeneous. It loses its fibular pattern kind of in this area versus their normal adjacent side, where it's nice, compact, fibular structure, kind of uniform in its appearance the whole way down. This tendon is thickened. We'll talk about that in a little bit, but it meets the criteria for a thickened or objective evidence for tendinopathy in the tendon. Speaking of which, this study looked at that to look to see if there's any objective evidence just based on appearance of the images alone. They looked at collegiate athletes that were jumpers, and they looked at them with both MRI and ultrasound and compared them to some age-matched controls. The shaded boxes here represent those with patellar tendinopathy. The non-shaded boxes are those without patellar tendinopathy. And you can see the proximal, they looked at three parts, the proximal, middle, and distal part of the tendon. And as you would suspect, the proximal portion in those with patellar tendinopathy, the tendon was thickened, whereas it didn't really become thickened at its midpoint or the distal region. And it turns out through looking at their data in a regression, using a regression model, that if the tendon is greater than 7 millimeters in thickness, then it was the most sensitive and specific for calling out the presence of patellar tendinopathy, whether it be with ultrasound or MRI. Jill Cook is a famous physical therapist, or physio as she calls herself, from Australia. She does a lot of work in tendon disorders around the body. So you'll see or hear her name a lot. She gave a talk at AMSSM maybe about 4 years ago. I think it was during COVID when she gave that. But her group looked at vascularity or neovascularization as well as size, and to see if it related to escalation of pain and reduction in function. So here you can see on this left scale here, those without vascularity did not have a lot of pain with a squat on a decline board. So they basically have them stand on a 25-degree decline board and do a squat. And so those without vascularity didn't have a lot of pain, whereas those with vascularity did have pain that was statistically significant more than those without vascularity. VISA is a function score, so it's a Victorian Institute Sport Activity Scale, and it is a well-validated, reliable measuring tool. They have a variety of different tendons in the body. This one would be called the VISA P score for patellar area. And regardless, those without vascularity had better function. So the higher the number, the better the person's functioning, versus a lower number would relate to a lower functioning person, right? So those with vascularity had a reduction in their function. Whereas when they try to correlate size with escalation, pain, reduction in function, they did not find any correlation between the size of the lesion as it relates to whether a person would have pain or reduced function. So it's all about those neovessels. And as I described before in the pathology slide, or that predictive slide, if there's neovascularization, free nerve endings are following those vessels into the tendon. And that's generally around when the patient would really present with to the clinic with pain. Before we go on to interventions, I'd like to show anatomic slides. Most areas are way more complex than we learn in medical school or kind of look at online if we're trying to familiarize ourselves. But this is the patellar tendon here in this kind of forcep kind of device. Surrounding the tendon is the epitendon. Most of these tendons like this and the Achilles tendon have a epitendon or a peritoneum. It's just connective tissue that kind of envelops the tendon. And then the tendon here is reflected off or pulled away from Hoffa's fat pad. That's this structure. And you can see how complex there is a connection here between the fat pad and the patellar tendon. And I show this because there's a procedure that we do that will kind of make sense because I divide this tissue with a tool to help treat the pain. There are some blood vessels in this area. Again, the neovascularization is really coming from this fat pad here, growing up into the tendon. And along with those blood vessels come the free nerve ending. So we do a procedure to try to divide this tissue plate here. And I'll show you that later. This anatomic description is from a while ago, but it's in the surgical literature, and they talk about the vascular supply to the patellar tendon itself. Most of it's coming from the volar surface, from regions above and kind of below the knee. Several arteries are feeding the tissue. There are some kind of vessels coming into the posterior or back side of the tendon as well, but it's not the primary supply. The primary supply is coming from the front. All right, so we're going to go on to interventions or treatments for this. All right, so as with most musculoskeletal things, some modified activities as well as exercise, in this case, strengthening exercises is really the primary key kind of concept that you would employ with patients with patellar tendinopathy. The exercises have kind of gone back and forth over the decades with treating it, but most people have kind of settled on either eccentric loading exercises or heavy to slow loading exercises. They've been studied a bunch of times in various settings, but there is a fair amount of work looking at treating the patellar tendon specifically with these loads. Eccentric, if you're not familiar, it's the negative, or where the muscle is contracting but lengthening at the same time. You have to recruit more motor units, which then imparts more force or load on the tendon. And they found that to be preferential over the concentric, or where the muscle is contracting and shortening. So this AMSSSM model uses predominantly eccentric loading, whereas this heavy slow loading, they don't really break it up into concentric or eccentric. They just do slow controlled loading of the tendon. Sometimes you have patients or athletes in season, and it's really hard to get them to do these exercises because they really need to be done vigorously, often, almost daily. You need to have some pain with it. So in an in-season athlete, like when I'm working with the Sounders, they are not wanting to do any strength exercises that are painful. And so, because otherwise they might not be able to play. So we're kind of left with lower intensity exercises, such as maybe isometrics, which helps kind of modulate their pain. It's not going to cure them, but helps get them through the season. Kongsgaard group looked at heavy slow loading, and they took subjects that did not have patellar tendinopathy and compared them to those that had patellar tendinopathy. And they must have paid them a lot because both groups got biopsies of their tendons prior to the intervention. And here's an example of a biopsy, histology of that diseased or subject with patellar tendinopathy. The fibrils are thickened or bigger. They're less densely populated than they would be normally. Then they instituted that heavy slow loading exercise routine over a 12-week period, and they got another biopsy of their tendon at that point. Here's an example of one of the histologic slides that they saw. And so these little dark black, kind of grayish dots here are the new fibrils that have grown into the diseased portion of the tendon. So these are more normal-like, they're more populous. So you can see there's actually histologic evidence that with at least this heavy slow loading routine, there is some healing of the tendon, whereas no one's really demonstrated that with eccentric loading exercises, at least not to that level. As with most things in musculoskeletal research, there's a lot of variability. But when people talk about eccentrics, they're really modeling mostly after Alfredsson's work. He's a orthopedic surgeon in Sweden, I think, that had Achilles tendinopathy and tried to get his partners to operate on him, and they wouldn't. And so he tried to break his tendon and tear it through heavy eccentric loading exercises. And lo and behold, he didn't tear it, but he fixed himself. So then he kind of was intrigued and studied that further. But anyway, his program is mostly 3 sets of 15 reps done most of the time daily, if not twice a day. This is pretty onerous. And then they'll exercise with some mild to moderate escalation in their pain during the last couple of reps of each set. And then once that no longer is painful, then they'll increase the load and kind of keep that progression going over time. The heavy slow loading program is a little less onerous. It's 4 sets of 3 exercises. So there's squat, leg press, and hack squat. If you're less familiar, hack squat is like a leg press, but it targets the quadriceps firing more than the leg press itself. So that's why they included it for the patellar tendon. It's 3 times per week and only once a day in this model versus every day, twice a day. They start off with high volume but low intensity, and then over a 12-week period, they increase the intensity, lower the volume. When you look at both groups show some response around 12 weeks. When they look at subjects and whether they like one more than the other, most of them will like the heavy slow loading. It's less onerous, it's less painful. It's more in line with what they would normally experience with strength training. In general, when you look at the studies, regardless of the approach, most patients will get better. You do still need to modify their activity somewhat, as much as you can, outside of the exercise. And it takes really 12 weeks before a patient may start to buy into this working. And I usually tell patients more likely 6 months before they're really out of the woods, because most patients aren't going to bite into this idea right away. It's going to take them time to become comfortable with exercise, or they're waiting to get into PT, or whatever the barrier is. So I usually explain to them, they'll leave physical therapy, they'll be discharged still with pain. They have to do the exercise to the end to see the results. Why am I showing you rats, right? So despite not so looking that ferocious or ugly, these animals have similar tendon properties as our tendons, right? And so when they look at tendon diseases and trying to mimic it, they often use the rat. So in this case, they were studying a rat model. They usually have them run on a treadmill to break their tendons down. And as they were surveilling the the tissue, they found that there was increase in different isoforms of nitric oxide synthase, which is an enzyme that makes nitric oxide, right? So they were intrigued by that. They made a rat model that did not have that enzyme. And then without inducing the tendinopathy on the treadmill, they just sacrificed it, the animals, and looked at their tendons, and lo and behold, they had a reduced cross-sectional area, and the tendons failed more easily without the presence of nitric oxide. So they took that same model and fed them nitric oxide, and then looked at their tendons again, and those abnormalities reversed, so they were more normal-like. So that then translated into humans, right? And so then most of this research has been done in Europe, where they have a slightly different formulation. So over there, they use 5 milligram per 24 hours. In the US, we don't have that. We have 0.1 milligram per hour patches, like the smallest patch. If you do the math, you're really cutting that patch in quarters. And that's how I sort of started using these, but I abandoned that a long time ago because most of the patients that use them are old. It's hard to see, and they're going to get a headache regardless of the dose. So I sort of became braver and just use a full patch, have them use it for at least a week where they're changing it daily, strolling during that window where they would have either a headache or maybe become a little hypotensive, and we can decide if we're going to progress with the medication or not. If they're not having any side effects, but it's helping, then I'll often encourage them to go up to 2 patches at a time over the target area. And then we'll aim for using it for about that 4 to 6 month window. Because like I said before, that's roughly how long the exercise program might take. So the patients perceive this as a thing or tool that can help reduce pain. Because of the rat model, there may be the potential for healing as well. We just haven't proven that in the human model. I show this picture because often patients will come back and they find the patches working, and then all of a sudden they're putting them everywhere in their body, and for other reasons. And I try to discourage that, but the goal is not to look like this, right? It's 1 or 2 patches, not the whole box at one time. Mural's group is the group that really studied this. They looked at using nitroglycerin versus placebo patches and around the body for a variety of different tendon disorders. And they found some mixed findings. So sometimes they found that it worked, sometimes they didn't find that it worked any better than the placebo patch. And they always included some kind of rehab. They didn't really have specific exercise plans, but they just talked about the patients would engage in these exercises. When it did work, so like around the shoulder, it worked up to took about 6 weeks for it to really kick in. Whereas at the elbow or Achilles tendon, it took a bit longer. I find it to work at the dose that I use, which is about 4 times the dose that they used in the research study, that it works within that week or two. If the patients can tolerate it, then we, again, aim for that 4 to 6 month window. To be honest with you, I don't use this one. Our group is just getting into using shockwave therapy, but it is a modality that you may come across in your training or read about or see presented. But there's basically 2 different types. There's focused and radial. Focused is more, I think, what people that are more knowledgeable on this than I am Think of this as a traditional shock wave where at the end of the tool, it's basically like it looks like an ultrasound kind of head. If you've seen an ultrasound used on a patient, the therapeutic kind, it creates a shock wave by either electrohydraulic, electromechanic, electromagnetic or piezoelectric, which is the conversion of electricity into sound waves. And those sound waves are traveling down into the body, kind of from a broad to a more focal area, kind of akin to how imaging ultrasound flows into the body from a wide to a relatively focused area. And then it's able to impart some perturbation in the tissue at a target depth. And the idea here is to cause some kind of injury or stimulate the healing response in a delayed or non-healing tissue, right? And so it's used for a variety of things. In this case, tendons. Sometimes people use it for stress injuries in bone or osteonecrosis in bone. Obviously, the deeper it is, the higher the energy you would need to use. This radial one is a little bit different. It's not classical kind of shock wave. People call it more akin to a pressure wave. It's sort of like inside of a tube, there's something that like a ballistic projectile that's like pounded into the end of the tube, and it creates this impulse or pressure wave that then goes into the body. That wave is not able to penetrate as deeply into the body. It's attenuated or absorbed before it can penetrate down deeply. So usually it's used more for superficial structures or maybe for treating nerve problems like neuropathies or myofascial pain that may be associated with another disorder like tendinopathy. But there's some evidence to support using shockwave therapy as a intervention in the US. It's a little challenging. It is not covered generally by insurance, so that makes it a barrier to a lot of patients. The cost of it's usually on the order of up to about $800. It's usually a series of treatments, 3 to 5, somewhere in that range, generally given at 1-week intervals. And it takes like 12 weeks for someone to really see any kind of effect from that. Orthobiologics, or PRP, which is platelet-rich plasma or stem cells, in this case, mesenchymal or adipose tissue, is what we're talking about. So we use PRP for a variety of different musculoskeletal disorders, but there's a lot of literature on its use in tendon disorders. For the majority of tendon problems that we would see around the body, there is a lot of heterogeneity in the literature as far as what people are using, whether they describe it or not. LR stands for leukocyte rich, LP stands for leukocyte poor. So these are basically the two versions that majority of people are using and or reporting they're using in the literature. Some studies show that the leukocyte rich works better than the poor, and vice versa. Like I said, there's a lot of heterogeneity. Some areas in the body respond better, more favorably than other areas, such as like the lateral elbow tendon has a lot more favorable studies than the rotator cuff or Achilles tendon. Bone marrow or adipose-derived stem cells. So in these two areas, you can harvest mesenchymal cells. Mesenchymal stem cells are the cells that can turn into tendon, bone, fibrous tissue, or fat. And so they're used for musculoskeletal injuries or injuries, diseases. There are a couple of articles out there relating to either the use of bone marrow or the adipose stem cells in using it in patellar tendinopathy, where they see improved characteristics in the tissue. I think it would be better if they would do some biopsies of the tissue like they did in that heavy, slow loading group. I think I would buy into it more that way. Tendons, I think they have the normal or intrinsic capacity to heal. So I can somewhat buy into these cells repopulating the tendon with some sort of tissue, whether it's tendon, fibrous tissue, or even like bone or fat it can make. Versus if you squirt it into the knee for knee arthritis, I think the model of knee arthritis is way more complex. There's way more tissue types that are involved in that. And I'm not buying into that growing anything in a predictable way in that instance. This is a different tool. It's called, I won't tell you the name of it, just to keep this talk outside of industry, but this is a tool that we use to debride or do this thing called a tenotomy on a tendon. So basically it's a needle at the head or the front of the needle. It generates a sound wave that has been shown in animal models to debride only the non-normal tendon tissue. So it's sort of cleaning out. My analogy for patients is like plywood, right? So you take plywood, it gets wet, swells, and that pulpwood, right, gets damaged. So this goes in and removes the pulpwood of the tendon, but leaves behind some structure. So you're not taking out large chunks of tissue. It's more at the cell level or interstitial region. So we place that under sterile guidance into the tendon as we're directly visualizing it under ultrasound guidance. So here's the device placed through the skin through a small incision. Using ultrasound here, and I can see the process occurring up there on the screen as I'm doing it. I'm kind of manipulating or moving that around within the disease portion of the tendon. This other, I'm going to stop that because it's annoying, that sound. So this other thing is basically what's called a meniscotome. It's borrowed knife more or less from arthroscopic surgery. So it's just a long-handled round tip blade that at the conclusion or after I'm done with 10x, I'll place it under ultrasound guidance through that same wound. And I use that to scrape the posterior surface of the tendon, trying to break that interface between the tendon and the fat pad that I showed you earlier. There's some research to suggest that what they call patellar scraping, some people use a needle, or some people use a high volume of fluid, such as a lot of saline, and they try to create a space or break down that interface in that plane. I find this knife to be way simpler, way faster, and I think patients actually get a better outcome. All that's anecdotal. I have no research to back that up. So this is just the process looking at this ultrasound images here of how the tenotomy is done. Here's patella, here's the patellar tendon. I'm showing you here, I'm numbing it up. So this white dot here is the needle on end. We call it out-of-plane technique. So I'll numb up the interface there between the tendon and the fat pad, kind of sneak up into the disease portion of the tendon and numb that up. I make an incision in the skin, and then I bring the tool in through that hole in the skin into the tendon. There's a way to turn it on and activate it, and it's kind of this jiggling of that device in the tendon, debrides or removes the non-normal tendon tissue, as I described previously. It's well tolerated. The patients are awake. I'm talking to them. Sometimes they're asleep and snoring. It's all good when they're doing that. Here, this is scraping. So this bottom left image is the sonogram. This is a short axis view of the patellar tendon. Here's the femur with the articular cartilage overlying the femur. Then you're going to see that meniscotome or that blade come in, again, through that incision under ultrasound guidance. And I'm using it to kind of scrape along the tendon. Here it is, where this is the tendon, this is the fat pad, and this white thing kind of moving back and forth is the blades that I'm using to scrape that posterior surface of the tendon. This is a process that was described and or written about by that same orthopedic surgeon, Alfredson, that I mentioned before. So in his case, he doesn't use ultrasound. He'll open up the skin and literally use a scalpel or scissors or something to scrape the tendon. And then at the conclusion, the goal of the scraping is to break down the neovessels and cut the free nerve endings. And the way we check that we've done that is by turning on the Doppler imaging at the conclusion of that procedure. And whereas before the procedure, there was a bunch of blood flow in the tendon, now you don't see any blood flow in the tendon. So that's when I say, okay, we're done with that part. You may think some of this is quite, it's kind of getting into the realm of like traditional surgical things. And there's a number of us, the number of us is growing in the US as far as using ultrasound to guide procedures, which are essentially surgical-like procedures. And so 6 groups throughout the country, I was part of this. It's a retrospective review of about almost 2,400 patients who underwent some kind of ultrasound-guided procedure. And what we're talking about here is carpal tunnel release, lower extremity fasciotomies, trigger finger or thumb releases, and then the tenotomy procedure that I just showed you. So not just like simple injections, right? And we found that our complication rate overall out of all these patients, with a number of different providers being involved in these cases, is that the complication rate was fairly small, 1.2% complication rate, all told. And most of those complications were not large, damaging injuries. It was some kind of deviation from our normal post-procedure where we had to give them some kind of medication, whether it was ice or Tylenol or tramadol or some kind of opioid medication for pain control. Sometimes the nerves, if you're doing like a carpal tunnel release or trigger finger thumb release, sometimes the nerves aren't damaged, but they get a little angry. So you use neuropathic medications to help control that process until it heals. And then for some of these like fasciotomies, sometimes they'll get hematoma that evolves post-procedure. And on occasion that will require some removal of the hematoma. Either we'll just make a large incision and kind of evacuate the hematoma and then place them on antibiotics just to cover them, make sure they don't get infected. But nothing where we had to send somebody to surgery to fix our mess. We're not really hurting patients, is more or less what I'm trying to tell you. So that's really the conclusion of the talk. So hopefully you learned something about patellar tendinopathy as far as like the risk factors and some of the pathophysiology of it, how you would kind of do an initial assessment from a physical exam point, and a little bit of differential, how you would image it, and then some of the mainstays of treatment. Really, the bulk of it really should be exercise driven. You might add in a nitropatch if you haven't heard of that before. And then these procedures, once you get out and practice, if you go down to musculoskeletal path, you may be doing some of these procedures for your patients in the future, or maybe there'll be something better. All right, so I'm going to stop sharing and look to see if there's any questions in the chat. Have you heard of using nitroglycerin previously for tendinopathies?
No, this is the first time I've heard of it. I was writing it down.
Yeah, I think, it's not unusual. I'm in our group in this area, probably I'm the one that uses it the most. If I think some of my colleagues are starting to buy into it somewhat, and we have a fellowship, so some of our fellows will carry that on. I think it's really safe, simple thing to utilize. Some patients will really find it to be really helpful. Others will, have to abort it right away just because of headaches and those sorts of things. But it's covered by insurance. It's really inexpensive.
How are you doing that? Are you actually applying it in the clinic, or are you prescribing it and having them apply it and then you're
Correct.
changing it?
Yeah. So I prescribe it for them. We have a phrase that we'll use to educate them on how to use it, because it's off-label use, right? And so we give them the directions both verbally and written. And then usually I'm following up with them virtually in about 2 or 3 weeks after initiating it, just to kind of see what's going on.
And then you're only doing one patch every 2 to 3 weeks.
No, it's changing the patch daily. So it's just like turning it over daily. Most pharmacists will say you can't wear it for longer than 12 hours, and that's fine, but we'll use it for 24 hours. And then after a week, if it's working but not enough, or they're not having a bad headache, then we can go up to 2 patches in one area. Sometimes people have pain or tendinopathies in more than one area, so I'm comfortable going up to like 4 total patches, which is really just the starting dose for angina anyways. So
There is a question that came up in the chat. What would lead you to suggest a tenotomy for a patient?
Yep. So it's a good question. It's like 4th in the line of things to do, really. So it should be modified activities and exercise. And then, in this area, I'm not a big fan, or I'm not a big user of the show pad strap, but there's a strap that you can use to try to uh, change the force or loading of the tendon. And then the nitro patch, or those are the things that I talk about first. I like to see that they either can't respond or they haven't responded and give them a good 8 to 12 weeks of that kind of plan. Sometimes they've come to me and they've already initiated all those things, right? And that they're really being referred to me for that procedure in particular. And then we have a conversation about doing that versus the PRP. Yes, so the next one is the hydro dissection. So people do that. There is literature, more like case reports on doing that to try to expand or open up the tissue plane between the tendon and the fat pad. And I did that for a little while, and then it's kind of messy, and I didn't really think it worked that great. And I found this knife tool and far enough down out of my training years that more comfortable using that. And I think I get a better result with meniscotome. And it's way less messy.
Do you have any last minute things that you want to add, Dr. Henning, before we conclude?
Well, I think a lot of these things, like, are things that I think will be around for a little while longer. I'm sure hopefully the field will get more knowledgeable, and hopefully we'll kind of clean up the literature on orthobiologics and make it something that we can glean some useful information from as a result. I think, at least in tendons, if we can do that, I think that would maybe open up some more treatment options for patients. A lot of the tendon problems, this in particular, the surgical solutions aren't great. Really, the surgeons are sending the patients to us because they realize that debriding the tendon with their arthroscopic tools isn't really doing it, or just exposing them to unnecessary procedures. So I think the non-operative folks are going to have to, figure this out, which I think we're doing. It's just, we need more people to help us.
Yes, exactly.
Mm.
All right.
Well,
Thank you.
thank you very much. I appreciate the opportunity. Hope everybody has a great night.
Thank you, Dr. Henning. And before we conclude tonight's webinar, I just want to encourage everybody else to join tomorrow night at 8:30 Eastern Time with the next webinar in their series, which is the MSIG webinar, Textbook Injuries, Alpine Winter Sports, with presentations on Dr. John Toby making a presentation on Nordic combined, Dr. Mardik Needfelt making a presentation on free skiing, and Dr. Samantha Stuick making a presentation on biathlon, and Dr. Jana Klein making a presentation on downhill skiing. And last, Dr. Meredith N making a presentation on snowboard. And on behalf of the members in attendance tonight, I'd like to thank Dr. Troy Henning for his amazing presentation, as well as thank everyone else tonight for attending our SRMC webinar. It was my pleasure serving as the moderator tonight. And this concludes tonight's webinar. Thank you.
All right, thank you. Good night.